start talking about issues related to drug administration. And this is going to be based on a PowerPoint from chapter 53 of your text. Drug administration is something that we need to learn to do correctly, obviously. This week's work with our last week's work assignment, rather, main assignment was to talk about the 7 rights of drug administration. So when you've studied, so you've had a chance to study that, you'll get, and those of you who haven't finished that assignment yet can do so. But the rights of drug administration are that we need to do, we need to give, among other things, we need to give the right drug in the right location, in the right, at the right, on the right schedule, by the right route of administration, and the right dose. And the patient needs to understand why they're being given the medication. One of the rights that does not seem to happen often enough is patients are not told why they're getting medication, and patients don't ask. So patients also need to learn to ask for the information as to why. But we have to, we also need to understand our scope of practice when we are administering drugs, because we're allowed to do some in the state as MAs. We're allowed to do some things, but not others. For instance, your MA certification and your MA position allows you in this state to give the injections that we're teaching, not in every state. So you need, if you move out of Colorado, you need to study the Practice Act wherever you're working and understand what you're allowed to do, and even more importantly, what you're not allowed to do. Because doing something that's not permitted under your scope of practice can cost you your job and any licensure that you have. And I've had students who have told me about being told by supervisors to do things outside their scope of practice. You have to say no, even if it costs you your job. And that's a difficult decision to make sometimes. But breaking the law is not good either. It's illegal for them to even request that you do something outside your scope of practice. So that's another aspect of it to remember. But we can give injections of the type that we have learned here. Intradermals are, used in allergy situations, but they're also used in places that you just need to numb up an area so that a procedure can occur. Sometimes that procedure is for someone who's trained in the process to go in with a biopsy needle. Sometimes, like in a dermatology clinic, they may take skin biopsies. In Colorado, we have a lot of trouble with skin cancers because of the thin air and the bright sunlight. In order to correctly diagnose a skin cancer, they have to take a biopsy. And for skin cancer, what that means is that they often will simply razor a piece of your skin off and send it off for testing. And the MA will come in and do that intradermal injection of a little bit of lidocaine, which is a very short-acting local anesthetic. That means that when you get that biopsy taken, you don't even feel it. I've had biopsies taken from my ears, and that sounds like a pretty painful place, but the MA that was giving me the intradermal lidocaine was very, very good. She was saying, I hope this doesn't hurt you. She was using, again, a very small needle. I looked at it and thought it was probably about a 29 gauge needle that she was using. But I didn't feel the injection and I didn't feel the actual taking of the biopsy. So these are things that you can do. Subcutaneous and intramuscular injections you can give here as an MA. You cannot set an IV. That requires special training. Now, some of you may, and I hope you consider this, get some experience as an MA and then go on into nursing or some other medical area. And then you'll find that what you're allowed to do will change. Okay, we're going to take, it's now 11 o'clock. We're going to take our break and then come back and finish this. I'll go ahead and put this on screen and we'll finish we'll go through this chapter 53. Okay, so go ahead and take a break. So let's keep going on this. What I'd like to do is get through a bunch of material on drug administration and then give you guys the last part of the class to work on assignments and project. Remember, you have a project due next week. It's a PowerPoint about some aspect of drug administration. That can be the technology that we use. It can be how you determine how to administer some drugs. It can be development of equipment that we've used. Be a lot of different things. So be prepared next week to present that in class. An important thing for you to do as a medical assistant is be aware of what your practice is. For instance, if you're working in a cardiologist's office, you're probably not going to see a lot of drugs used for allergy. You're going to see mainly cardiovascular drugs, drugs for some of the more common cardiology conditions, such as elevated blood pressure, congestive heart failure, the kinds of things that you might see. Ancillary drugs in a cardiology setting would include the anticoagulant Coumadin, because a number of your patients will probably be wearing implantable pacemakers. Okay. On the other hand, if you're working in a clinic that deals mainly with diabetic patients, then you want to be able to know the most common of the drugs that are used in that setting. So again, it's a case of learning about your setting, and when you are actually working there, finding out that information. What should you know? So you need to know the most common drugs that are being used and the problems your patients may experience with them. This is so that you can be aware when a patient is no longer responding well to a drug or having a problem on a drug. I told you about my brother-in-law taking a drug for his type 2 diabetes, and his side effect was that his food tasted awful and he just wasn't eating. The clinic should have noticed that he was losing a large amount of weight. Now, given his size, losing a large amount of weight was probably good for his diabetes too. But nonetheless, when that happens, they didn't even ask the right questions. And he ultimately changed to a different drug and is doing much better. When you're going to do any kind of administration, or when you're actually interviewing your patient, you're going to ask about drug allergies. Patients can be allergic to anything. We think of things like the surgical steel that's used in some and titanium used in some implants. Um, People who get their knees or hips replaced is often with a metal. And believe it or not, people can become allergic to the metals of all things. And that's a growing problem, so we need to be careful with that. People can be allergic to anything, and that includes foods. Food allergies are important to understand as well with your patients. Many of us are allergic, for instance, to penicillin. We receive penicillin as babies, and then many years later, we turn out to be allergic to it. That's a great way to show up with an allergy, to take something for a period of time when you're young, be away from it for perhaps even for a long time, years maybe, and then then you're allergic to it. Also, make sure that your family knows that you're allergic, and can prevent, in the case of being unable to actually say anything. We had a case recently with a cousin of my wife who is very allergic to some of the opioids, which is probably not a bad thing in some ways, but they're overprescribed and overused, and was not able himself, because he wasn't conscious, to inform the medical staff that he was allergic to this. And for some reason, they missed it in his records, and his wife had to stop them from administering the drugs to him. So these are things that we need to know. When we're preparing, we need to make sure that we check the administration site. For instance, we've talked about the fact that we don't inject through tattoos because of the ink. We also don't inject around moles. And although we can use things like a birthmark or a freckle or some other mark on the skin as a sort of guide to where we want to inject, we don't inject through them. Okay? As I said before, on the belly today, we don't inject within an inch of the navel. The patient condition. Vaccines are especially, you want to be careful with this. With vaccines, you need to make sure that your patient isn't sick, because then their immune system is compromised and they can have complications. Another cousin of my wife went to the doctor, was ill. The doctor ordered a pneumonia shot. And the doctor did this, and she was sick. She went in with a bad cold. She developed Bell's palsy and still has an after effect of that injection, and that was 2 years ago. So, make sure that you look at the patient conditions. The patient consent form that they signed that we talked about in the lab, be prepared to answer questions about that form. Let them read it. I'm a person who, somebody says, here, sign this. I read it. Never sign anything you haven't read. And don't try to convince your patients to sign something without, oh, that's just a consent form. Okay, great. I'm still going to read it. And they can wait, because that is when you get into trouble. And if there's something you don't understand, ask a question. They have to be able to answer it. If they can't answer it, well, who can? Okay. We only give drugs on doctor's orders. That includes OTC products. In the clinic, we don't give anything to a patient without a doctor's order, even an aspirin. Say. So again, always wash your hands, be focused on the task, triple check, okay? What you want to do is make sure that you check that you've got it's the correct medication, and check the dose that you're giving. So you take it when you take the drug and you match it to the medication administration record, the MAR. That's a part of every patient's record. Okay? So you check and make sure that it's matched to what is ordered. You check it again when it's prepared, and you check it again just before administration. Okay? If you have to calculate the dose, do it carefully. And you may very much want to have someone just be sure that you've done it correctly. Don't leave any drug that you've prepared unattended. You don't know what's going to happen to it if it's out of your sight. Don't administer a drug that you didn't prepare. Here, give this to the patient. What is it? You know, don't do that. And of course, you want to verify the patient identity. We have the 2 rule. The video that was associated with last week's assignment has some ideas for that. The most common is first and last name and birth date. Okay. First and last name and birth date. There was a very nasty event that happened in Fort Lupton, actually, several years ago, where a patient came in to pick up her prescription, and she happened to have the same first initial and same last name as another patient. She was given the wrong prescription because the person did not check to be sure about birth date. Okay. Generally speaking, the physician has to be in the office in case there's a problem, and the patient remains in the office and receives their instruction. If the patient refuses, which they may, we cannot force a patient to take a medication of any sort, oral, injected, or anything else. Then we need to make sure that that is properly disposed of, and we need to document that the patient refused. The patient, usually the consent form has a place for the patient to say that they've refused and sign off on it. Make sure they do. If there's an error of any sort, this error could be the wrong dose, could be the wrong drug. It needs to be reported immediately. Okay? And then you need documentation as well. The rights of administration you can read through. In the clinic, you need to be able to safely give drugs by any route. We'll talk about either later this week or next week as part of our work. We'll talk about other routes of administration, such as using an inhaler or any of those things. Inhalers are different designs, and each of the different designs has a different method of use. Okay? Topical drugs sometimes have to be given very specifically to locations on the body. With a topical drug that's done by a transdermal patch system, which basically is something you put on the patient's skin. It delivers drug at a regular rate for usually no more than 72 hours. When we have to change that drug and give them a second dose, we do it in a different part of the body, because when we put a transdermal patch on a patient, we cover their skin. It makes the skin get oxygen starved. And you've all seen what happens if you leave a Band-Aid on too long, the skin gets kind of white and wrinkly. That's because it's been oxygen starved, it's being damaged. Now, skin is real good about recovering. So you take off the Band-Aid and within a couple hours, you don't even know you had a problem. But that's why we move every time we use a transdermal patch, we move it. We're very careful with how we place them, because especially patients that are in nursing homes, and even worse, patients of dementia, will try to rip them off sometimes. So we need to place them in places for those kinds of patients where they're not going to be trying to tear them off, and therefore not get the benefit of the drug. We have lots and lots of dosage forms that we take. In oral administration, we talked about the fact that it's the slowest absorption. On the other hand, it's the easiest medication to give because all somebody has to do is swallow it. We have tablets. We have scored tablets that can be broken in half. You'll find lots of medications you'll be told to give somebody half a tablet, or even a third of a tablet, or even a quarter of a tablet. They used to sell a lot of aspirin that was scored to be cut in half because low-dose aspirin is used for its cardiovascular effects. We have capsules, lozenges, which are basically like pieces of candy, and liquids. What happens with when we can't give these drugs? Well, patients who are nauseous, we don't put things in their stomach. Okay, many drugs can be given to patients that are nauseous that are available in alternate forms, mainly suppositories and sometimes patches. A patient who is comatose, obviously you're not going to put anything in their mouth, or unable to swallow for a variety of reasons, including surgery. A lot of this is teaching patients. Buccal administration is between cheek and gum. Sublingual is under the tongue. These actually are pretty fast. They bypass the GI because what you're doing, the oral mucosa, the tissue on the inside of your mouth, is permeable. And drugs and foods will absorb right into the bloodstream. Some foods will absorb right into the bloodstream by putting something in your mouth and just letting it dissolve. So when we do this, we teach our patients to just let them dissolve rather than chewing them up and swallowing. Okay, and in fact, especially with sublingual products, they're designed to really literally disintegrate as soon as they get into the mouth, so that they can deliver the drug. Okay. Injections, well, we've talked about that. We've talked about the needle. The needle itself has a hub, the plastic part that actually goes on to the syringe. The lumen is the hollow, the space in the hollow of the tube, and the bevel and the point we talked about, and the lumen size and the length of the needle depends on what we're doing. The syringes, their design is there's a barrel that which is a calibrated cylinder. You've seen that. And then the plunger. The end of the plunger, the leading ring on the end of those plungers, is where we measure the amount. Syringes can be anything up to 60 milliliters, 60 cc's. Now, I will tell you that a 60 cc syringe is used largely for doing things like flushing catheters. Okay, we don't give that much drug to a patient. Can also be used with enteral nutrition, meaning feeding through a nasogastric tube directly into the stomach. Sometimes we can actually feed through a large syringe. Syringes are calibrated generally in milliliters and cc's. Remember, they're the same thing. However, syringes that are used for diabetics, for dosing in dosing diabetics, we're giving them insulin, are calibrated in units of insulin. So when someone tests their sugar, they're given an instruction as to how many units of insulin they need. The standard formulation of insulin, there is 1 unit, there's 100 units per milliliter. So our 1 cc syringes are graduated in 1/100ths of a milliliter. So each of those 1/100ths is equivalent to 1 unit of penicillin, standard penicillin. So we can use those. It's easier to teach a diabetic to match the number of units than to convert it to cc's. Packaging, we've seen ampule, we've seen vials. An ampule is a glass container with a neck on it that you have to actually break open to get the contents out. They are always single dose because we don't pack, what we package in ampules generally does not have any preservatives in them. A cartridge is merely a device that can deliver lots of doses. Obviously, you have to change needles if you're changing patients and that sort of thing. Vials you've seen, we can have either single or multiple doses. We're using multi-dose vials in the lab right now because, and we can do that because they have preservatives in them. So we've talked about the various routes of administration by injections. We'll worry about those. We can look at, we'll look at various other routes of administration. Babies generally get this vastus lateralis there on the right, is the common spot for injecting babies. Intravenous drugs are given by either bolus, meaning you just put the needle in the vein and squirt the contents into the patient, preferably slowly so that it doesn't hurt, or infusion, which is over time. You've all seen the infusion pumps in the hospital. There are issues with that. So other routes, inhalation, there's lots of ways of doing that. It can go up through the nose or the mouth. Inhalers are common. The incidence of asthma is rising rapidly. It's one of the it's a very common condition. Asthma patients will take a couple of different kinds of drugs to treat their disease, one of which is something they take regularly, several times a day. And the other is what they call the rescue inhaler, which is when they really have a hard time breathing. The bronchodilator is a rescue. So the two different, there are several different kinds of these things. Well, most of them now come as a metered dose inhaler, meaning you simply push the dosing device and you get an exact dose of the drug as required. And the way we control the amount of the dose is the number of times you take a puff off your inhaler. We also have dry powder inhalers that you have to really learn to use. The lungs hate solids. They hate to inhale things. Think about just being somewhere where there's maybe a campfire and how the smoke will choke you and you'll start coughing. The lungs hate that. You have to train yourself to be able to take these inhaled medications because it's not normal. The lungs are a great place to absorb drug. They're even faster than the mouth, the sublingual and buccal route. Not as fast as IV, but very close. So we use these things sometimes. Topical We have creams and lotions. We also have the transdermal systems, the patches. Other medication routes can be through the urethra for a local effect, usually for some forms of kidney infections and other things, but also for inflammatory conditions that affect the urethra. We have suppositories and other forms of drugs that can go into the vagina and the rectum. Hello, Katie. Yep. Oh, okay. Thank you. I didn't get that yet. I haven't had a chance to check. Okay. Thank you, Katie. We also have rectal. These can be suppositories or enemas. I don't know if any of you have had the dubious pleasure of receiving an enema. It's not my favorite thing. My grandmother taught me not to complain of constipation by giving me an enema. Very unpleasant experience. And after that, no, Grandma, I'm fine. So we learn. She also taught me not to complain of a cold because she used to put something we called a mustard plaster on the chest, very hot, pungent thing that used mustard, not French's yellow mustard, but mustard plant. And it would open up your chest, all right. But it taught me not to tell Grandma I had a cold because it wasn't very pleasant. Okay, there are a lot of special considerations we have to make, especially with our younger and older patients. Pediatric patients, drug effects are less predictable because their systems aren't developed. Also, remember that their livers haven't been assaulted by life. By the time we get up to about teenage, we've been eating, we've been putting things into our bodies that have really that have changed the way we handle things. But we have to adjust doses and very carefully measure them for children because it's easy to overdose a child. Children, we talk about children as though they're small adults, and physiologically they're small adults, but biochemically they're still not developed. And especially their immune systems are not well developed. Okay, we have to watch these things and look at the sites and techniques that we can use. For instance, you wouldn't give a baby a tablet, obviously. Use liquid. That's why we have all sorts of things like oral syringes and stuff for dosing children and babies. Also, with education, it's really kind of interesting. You guys saw the medicated child video, and we didn't have a chance to talk about that yet. I would love to hear your reactions to it beyond what you already wrote. But you noticed that some of the physicians would talk to the child, and some of the physicians would only talk to the parents. Well, as a parent, and I know perfectly well that babies or children have the ability to understand a lot more than we give them credit for. So we need to be aware that in terms of the education part, we need to talk to the kids and the parents both. The parents are responsible for the children, but if we treat the children like they can understand it, they will. Okay, so the injections, the main site for injection here is the vastus lateralis. This from about a third of the way down the thigh to about a quarter of the way up from the knee is that nice big muscle, and that's where we give most of our babies their injections. That muscle extends to about mid front of the thigh. So again, we give the injections there, and we look at how we can restrain children. You saw again in the vaccine video, you saw that one child who was just throwing a fit, and 3 people were trying to hold the child down while the other person gave the injection. There's lots of ways of approaching that. Our older daughter was exactly that way. She wasn't autistic or anything. She isn't. But she was the same way. You brought a needle into the room and she started thrashing. Well, one day my wife had the brilliant idea of talking to her about one of her favorite kid movies. And so got her talking about that. And she received the injection and didn't know it because she was distracted. And after that, they weren't so bad. So it was a good lesson for all of us. We have another cousin who goes, again, you just want to strangle some people, who goes into gory detail with her kids before she takes them to the doctor's office and scares them to death before they even walk in. Well, they have to know. No, they don't. You know, you don't have to scare them. Yeah, you can say, yeah, you have to go to the doctor, but you don't have to scare them. Her daughter one time had to have blood drawn. That was a nightmare. Pregnancy. Lots of drugs can't be used in pregnancy or breastfeeding. Some drugs, when you're breastfeeding, some drugs will be secreted in the milk. And we all know that breastfeeding is really critical to the development of a baby. But we have to be careful that we don't dose our babies with drugs. When our kids were nursing, my wife didn't take any drugs, not even aspirin. So over-the-counter drugs, you need to understand that over-the-counter drugs are no different than anything else. They have side effects. They have drug interactions. They don't work in some people. They do in others. You have to be careful with these multi-component products like cough and cold formulas that will have an antihistamine and a decongestant and 2 or 3 other things that you may not want to be taking. So patient education is critical. When to take a drug, as we've discussed before, some drugs need to be taken with food. Other drugs need to be taken before or after eating some period of time. Some drugs need to be taken at night only. Other drugs we take in the morning so that we can have the best effect throughout the day. Drugs like warfarin, the oral anticoagulant, drugs like levothyroxine, and most of the once-a-day blood pressure meds need to be taken in the morning. A suspension, drugs that are liquids. A suspension has solids that are not dissolved. So what we want to do with those is make sure the patient shakes them well. Okay? We need to educate the patient that if they have any problem at all, that they need to contact the doctor, especially if they're on multiple meds, because we can have interactions. We can have interactions with food. There are some drugs that we cannot take, that when we take, we cannot eat grapefruit, for instance, because grapefruit interferes with the way the liver metabolizes them. So there are, and we need to tell patients again, without scaring them, because if you listen to a drug commercial on TV, they go through this incredible range of side effects and problems to the point where you're afraid to even take the drug. And that's just a requirement. But the issue is that a patient should be aware of potentially bad side effects. There are very rare side effects that we can ignore, but patients, as I said before, can be allergic to anything. So we need to keep them aware of what means allergic. Some drugs will be affected by alcohol. Some drugs will interact with alcohol. Almost all antidepressants interact badly with alcohol. All opiates interact badly with alcohol. If you want to commit suicide, swallow down your hydrocodone tablet with bourbon or whatever else you might prefer to drink. Bad idea. In fact, a few years ago, one major route of committing suicide by college students was to take a bottle of Tylenol and swallow it with alcohol. Tylenol is a liver toxin. Alcohol is a liver toxin. You know, although livers will regenerate, you have to have one that's working to regenerate. So people would do that. Keep an up-to-date, or encourage patients to keep an up-to-date list of all their meds. One of the biggest problems you run into is trying to figure out what patients are taking, what drugs patients are taking. Compliance is a problem with drugs. Make sure the patients understand why they have to take them and when and how long. One of the biggest things that we run into, one of the reasons we have a problem with drug-resistant microorganisms is that patients will take half of a prescription and then they feel better and they stop, and then the bug comes back and it's resistant to that antibiotic. This has been a major problem. So we need to educate our patients about these things. Compliance is taking drugs the right time, the right doses, and continuing through. There are drugs that are to be taken as needed. Nitroglycerin taken for angina, which is heart pain that comes with having a partial blockage to a coronary artery and can be a precursor to a heart attack, is only taken as needed. And then if it doesn't work immediately, which means within a couple, 3 minutes, you take it again, and if that doesn't work, you go to the hospital. We need to educate our patients. What do you do with old meds? Well, it used to be you could take them back to the pharmacy and they'd dispose of them. Most pharmacies won't do that anymore. So at least in Loveland, I can't speak for every other city in the area, but at least in Loveland, once or twice a year, we have a take-back day where you can just drop your old medications down by the police station and they put them into medical waste containers and take them out and properly dispose of them. Storage, some drugs need to be refrigerated, some drugs don't. Find out. Okay, so that's what I want to say about that. So for the rest of today's class, work on your project, work on your discussions. Let's take a quick look at the at this week's assignments. We're in week 3 now. Come on. The discussion concerns homeopathic medicine. So if you don't know anything about homeopathic medicine, read my first post. It'll give you something. Look it up. It is something that's been around for a while. Actually, the whole principle is ancient. Okay. Your assignment is to look at manufactured and compound drugs. Now, what this actually means is, remember from, let's get over there. Come on. Wake up. Wake up. Well, it's not cooperating with me, is it? They're talking about the differences between manufactured drugs from a FDA licensed manufacturer and compounded drugs. Remember from COM 103, pharmacies will compound drugs as needed according to physician orders. So this is about the difference between manufactured from a pharmaceutical company and compounded by a pharmacy. Okay, and we'll do the assessment in class on Wednesday. Here we finally are. Boy, that's being slow today. I wonder what's going on. Okay, so let's take a look at this. Compare and contrast the process of calculating a manufactured drug and a compounded drug. So look at that, okay? In what situations might a compounded drug be prescribed instead of a manufactured drug? And what are the difference in how they're regulated? So you need to do a little research on this. So do a little research on this assignment. The information is there. Why are compounded drugs not FDA approved? So look at these things. And if you have questions or you don't understand some of these questions, ask me either in class or email me. I'll be perfectly happy to talk about that. Okay. All right. As I said, the discussion is discussing your stance on homeopathic medicine. I have not taken a stance in my post. I don't want to inadvertently influence anyone's thoughts on this. Homeopathic medicine is used in most of the world. Homeopathic and naturopathic medication. I will confess one thing. My primary physician is a naturopath. I don't like drugs. I teach all about them. I worked in that industry for 25 years. I don't like drugs. Natural products do have their place. Okay, so that's what this week's assignments are. So go ahead and work for the rest of class period on your project and anything else you have to do. If you have any questions, I'm sitting right here. So.